Good morning, everybody. Dr. Vasquez here, coming to you bright and shiny, as I usually am in the morning. Actually, not so bright and shiny today. I haven't even had breakfast yet. But last night, I did a spontaneous review of the recent vitamin D guidelines published by the American Medical Association. And hopefully you've seen the video by now that I did. I posted it last night and again this morning. And in the process of posting that video last night, I saw that JAMA had published a video review of presumably their own recycled bullshit. So I didn't have the expectation to do what I'm going to do right now, which is a video review of their video review. This is available on their YouTube channel. I'm gonna play the video, and maybe every once in a while I'll stop and comment on it. But I just want to see what they've said. Since I'm already kind of in the theme of vitamin D and reviewing their anti-nutrition propaganda, since it's early in the morning, I thought, well, I'll go ahead and continue that theme right now. So I haven't seen the video. It's 18 minutes long, which is a bit long, actually. I mean, in that much time, they could reform healthcare. So what I'm going to do is play back the video and watch it and do a little commentary. I'm going to try to play it back at 1.5 speed, so that makes this review a little faster. If that's too fast, then of course I'll slow it down. My goal in getting through this is to see what they say, debunk what's bogus in it. But one of the ultimate outcomes of this exercise, in addition to the video review that you're seeing right now, is that eventually I'm going to publish a paper. I've already talked to the journal. I've already talked to the editors. So I'm working on a publication that's going to list kind of their propaganda strategies. Not simply JAMA and the American Medical Association, but the way that all journals engage in this anti-nutrition propaganda. So right now my list, and the short version of my list has 21 items. I'm sure I could expand that easily to 30. And in the review that I did last night, for example, I itemized a few strategies and tactics that were used in that recent editorial, again published in the Journal of the American Medical Association. And so what I'm going to do as I watch this review is probably take a few notes and type out a few details, and I'll try to cut and paste that into the video or onto the page where I post the video so that you get to see that. It's not going to be any big secret. But again, what I'm trying to do is I want to analyze this, but ultimately I want to have something organized that I can publish. So you've seen some earlier versions of that. I published the first version was 18 items, and then I went to 21 items. But even that's a short list. It has at least 30 items. And again, like I said, I'm preparing this for publication in a Medline journal, Medline PubMed journal. So eventually you'll be able to see the whole thing once it's kind of formalized and cited and peer reviewed and all that kind of stuff. So let's dive into this. This is published on the YouTube channel of the JAMA Network. Vitamin D guidelines for healthy children and adults. So again, I expect this to be pure psychobabble clusterfuck, but let's see what strategies they use in that regard. So like I said, I'm going to take a few notes as I go through this. I'll incorporate those notes into the video one way or another, either text or verbally. But mostly what I'm going to try to do is just watch the video and see what they say. So let's start that process now.
From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thanks for being here. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing vitamin D for the prevention of disease. I'm joined today by Dr. Sherry Ann Burnett-Bowie, who is an Associate Professor of Medicine at Harvard Medical School. Dr. Burnett-Bowie is an author of our clinical guideline synopsis on vitamin D in the April 23, 2025 edition of JAMA. Dr. Burnett Bowie, thank you for joining us today.
Thank you so much, Dr. Simel.
Let's start our discussion today at a very basic level with the definition of a vitamin and whether vitamin D is a vitamin or something else.
So a vitamin is something that our bodies cannot make. Vitamin D can actually be made in our skin if we have enough exposure to sunlight and we actually are unclothed enough to be able to make that vitamin. So vitamin D, I would categorize as something else because between our exposure outside, how much clothing we're wearing, whether we're using sunscreen or not, most of us do not get enough sunlight to be able to make vitamin D in our skin. And thus we are reliant on foods that either naturally have vitamin D or foods that are fortified with vitamin D or supplements.
Well, which foods are the natural sources of vitamin D?
So foods that are natural sources of vitamin D include the skin of fatty fish like trout, salmon, tuna, mackerel, fish liver oils. And then, relatively speaking, there's a far smaller amount of vitamin D naturally in eggs. So by way of example, in 3 ounces of trout, there are 645 international units of vitamin D. For the duration of the conversation, I will be using international units. However, if you are one of our listeners who uses micrograms, the conversion from international units to micrograms is by dividing the international units number by 40. So while 3 ounces of salmon contain 570 units of vitamin D, 1 large egg has 44 international units of vitamin D. White mushrooms exposed to UV light, a half cup, will contain approximately 400 international units of vitamin D. And then fortified milk or any of the non-animal based milks like soy, almond, oat milk, they are also fortified and they contain roughly about 120 international units of vitamin D. Foods that are made from milk, like cheese or yogurt, are typically not fortified with vitamin D.
Well, in addition to getting vitamin D from sun exposure and the natural food sources and the fortified food sources, many people seem to just empirically be taking vitamin D supplements. Are there any adverse effects from supplemental vitamin D?
So the recommended upper daily allowance in health, again, based on the recommendations in the United States, is 4,000 international units daily. If you're under care and you're being recommended to consume a different amount, then that's a distinct situation. But the recommended daily upper intake is 4,000 units in health. The greatest concern in terms of a complication of taking too much vitamin D is that you will have increased absorption of calcium that you may be consuming either from your diet or from supplements. And that increased absorption of calcium will lead to either elevated blood calcium levels or to kidney stones. For most people, this is very unusual, but those are the potential complications of taking too much vitamin D.
Well, while all of us recognize the role of vitamin D in skeletal metabolism and mineral homeostasis, this particular guideline looked at vitamin D for the prevention of other types of diseases in healthy children, adolescents, and adults. And the guidelines evaluated vitamin D in healthy children for lowering the rate of respiratory infections, in adults 75 and over for lowering mortality, and in those with prediabetes for decreasing the progression to diabetes. I'd like to go over each of these. Can you review for us the basis for the suggestion of vitamin D supplementation to lower the risk of respiratory infection in children age 1 to 18?
When we think about vitamin D, we think about it normally being metabolized from 25-hydroxyvitamin D, which we measure clinically to assess vitamin D stores, that it is then hydroxylated in the kidney to form 1,25-dihydroxyvitamin D, which is the activated form of vitamin D that does all of the different important functions in the body.
So I'm just going to obviously pause the video just for a second. So we're 6 minutes into this and it's actually quite accurate. I'm not picking up a lot of spin, even though it has a little micro spin to it, but it's still reasonably good. The part that's being spoken right now about cholecalciferol vitamin D3 being converted firstly in the liver to 25-hydroxyvitamin D and then in the kidney to 1,25-dihydroxyvitamin D. That's kind of the old way of looking at this. I'm not saying that that's inaccurate, but it's incomplete. So for the past 14 years, we've known that 25-hydroxyvitamin D isn't simply the storage form, but it also has biological activity, a lot of biological activity. So what they're saying is accurate, but it's incomplete and a bit outdated. But otherwise, this is, we're 6 minutes into this, almost half. And most of what they've said so far is accurate. So I have to give them a thumbs up so far. We're okay so far. Let's see if they screw it up.
Very interestingly, macrophages, very key immune cells, contain that 1 alpha hydroxylase that takes vitamin D from the dietary measure 25 hydroxyvitamin D to the activated measure 125 dihydroxyvitamin D. So this is really key, this idea that our immune systems require a certain amount of vitamin D to facilitate immune function. What that amount is, it's not clear, but this may be one of the reasons for what was observed, which was vitamin D in children was associated with a decreased risk of respiratory tract infections and in particular pneumonias. This impact on pneumonia is very important because in children under the age of 5, pneumonia is the leading infectious disease cause of death. Secondly, tuberculosis is a major cause of morbidity and mortality in children. And that activation to the active form of vitamin D in macrophages, that is really key to creating cathelicidin, which is a key factor in our cells that kills tuberculosis. So the pathway to vitamin D having supplementation in children to prevent infection is one of the clearer ones, and it really has to do with what's occurring in the immune system in generating this activated vitamin D moiety.
You say the pathway is clear, but the effect was actually rather small.
Yes. So the effect in terms of respiratory infection did include, in terms of the confidence interval, the potential of zero effect. Zero was included. The consensus panel.
So this is still okay, but you can see they're subtly starting to screw this up a little bit. And the way that they're screwing it up is they haven't talked about what dose was used in the study. So, for example, if they're saying that the clinical benefit or the clinical effect was small, that can really only be accurately discussed in terms of what dosage was used. If the dosage was inadequate, then of course the clinical benefit would likewise be inadequate. And typically that's one of the strategies that they use to make nutrition appear ineffective is they either delay treatment, or they use such a small dose that it's ineffective, or they use such a high dose that it's toxic. But I almost never see studies that use an appropriate dose. So, the dose for kids should be 2,000 international units at least. And the other thing is, and I've mentioned this before, but when we talk about children, the range of body weight and size in children, children is any kid from 1 year of age to 18. So, a 1-year-old kid might weigh, 40 pounds or whatever. An 18-year-old kid could weigh 200 pounds. So obviously the dose has to be considered. In any conversation on antibiotics or anti-seizure drugs, they would be talking about dosage. But that's one of the strategies used to confuse the conversation on nutrition, is they don't include that obvious basic pharmacology nuance, which is you have to give the appropriate dose of the therapeutic. So you'll, even without mentioning it, and that's the strategy, is they're leaving this topic to be somewhat blind in the eyes of the listener, because they're not talking about nuance. What is the age of the children being discussed here? What was the dose used and what was the timing? In one of the JAMA studies that I reviewed back in 2021, they delayed treatment in acute COVID by 2 weeks. And then they said, well, the vitamin D didn't work. Well, of course it's not going to work if you wait 2 weeks. No antibiotic is going to work if you wait 2 weeks in the treatment of infectious disease. So let's just see where they go with it. But again, we can't talk about clinical efficacy without talking about dosage per size of the patient.
Recommended empiric treatment still with supplemental vitamin D in children because of the concern of comorbidity and mortality related to low vitamin D and infection. And then secondly, because of the inexpensiveness of taking a vitamin D supplement, and also the expense related to testing and the healthcare associated with being tested. So while there may have been a small demonstrated impact with the potential for there to be a null effect because zero was included in the confidence interval, because of the epidemiologic data that exist, because of the physiology, which truthfully was not necessarily included in the guideline, but it's something that has been discussed.
Oh, so they didn't mention the physiology in the guideline. So that's another way that they confuse the topic is by not presenting all the data. So even her mention of vitamin D in the immune system was grossly incomplete, but at least she talked about it a little bit. But then she's saying that in the guideline, they didn't even talk about mechanisms. That's a way to keep this whole conversation vague and, oh, well, we don't know if it works, and we don't even know if there's biological plausibility for it to work. So you can see they're getting a little bit, loose with their scientific rigor. Scientific rigor apparently never applies to nutrition reviews in JAMA and the big journals. So let's just see where they continue with this.
By many people who do vitamin D research. Ultimately, the recommendation was made for children. In addition, because there is a potential for rickets and the impact on musculoskeletal health, that was again another reason for supplementing children with vitamin D empirically without measuring their 25-hydroxyvitamin D levels.
So the recommendation from the Society for Children aged 1 to 18 was to take supplemental vitamin D to achieve a small effect. And there actually may be no effect if you look at the results. But what about the decrease in mortality for those 75 and older? How strong was that effect?
For the individuals who are ages 75 and older, that was when there was a recommendation for additional empiric vitamin D. The effect, once again, with regard to mortality in that particular age range, did include 0. So there is the possibility of no effect. However, in terms of what was observed, they observed that there was a reduction in death of approximately 6% with vitamin D supplementation of 9.
So again, in the world of vitamin D conversations in major medical journals, this has been a reasonable conversation so far, except for this point right here, where they're talking about using 900 international units for adults. I mean, that's completely inadequate. So when I wrote the vitamin D paradigm shift in 2004, even then, a conservative recommendation was 2,000 international units for children and 4,000 international units for adults. And here she is talking about 900, and the recommendation for adults should have been at least 4,000. So they're only giving less than 25% of the physiologic requirement here based on the clinical trial published by Robert Heaney in January of 2003. So you'll notice the lack of sophistication in this conversation. I mean, they're ignoring data that is definitive data published 22 years ago, and they're not even talking about it. And that's why they're underdosing, and that's why the effect range is rather small and modest.
900 international units. That would have been in addition to the recommended daily intake of 800 units.
Well, we all recognize the very high prevalence of prediabetes. And for those affected patients, the guidelines suggest that additional vitamin D might decrease the risk of progression to diabetes. How much vitamin D was used in the clinical trials that evaluated prediabetes, and what were the effects from those trials?
The challenge with these analyses were that the vitamin D dose actually varied across the different studies. There were 10 randomized clinical trials that were studied. In addition to the vitamin D dose varying, the duration of the studies varied from 6 months to 60 months. What they observed was that taking approximately an average weighted daily dose of vitamin D that accounted for the differences in doses and the differences in duration, but an average weighted daily dose of 3,500 units of vitamin D resulted in 2.4% fewer individuals progressing from prediabetes to diabetes. Again, the confidence interval did abut 0, so there is the potential for there to have been no effect, but on average, the risk difference was 2.4% fewer people developing diabetes from prediabetes.
So to put that dose in perspective, I believe you said that the recommended daily intake for adults over age 70 would be, somewhere around 800 international units, 600 to 800 international units. And in these trials that were summed up in the meta-analysis, the average dose was 3,500 units.
That is correct.
And then once again, we have an effect that maybe could be important if it's real, but there's a possibility of no effect.
Correct.
Well, the guidelines suggest not screening healthy children and adults with serum 25-hydroxy vitamin D levels to either guide decision-making about whether to take a supplement or to guide dosing in those taking supplements. What are the pros and cons of using serum levels in healthy persons?
So the challenge is that, and this was discussed in the guideline development panel could not find clinical trial evidence that would support establishing distinct 25-hydroxyvitamin D thresholds that would be tied to specific outcome or benefits in the populations that were studied.
So again, they don't want to find the answer. I mean, I published a small kind of infographic back in 2021, I believe. And even then, the data was actually quite clear. So they're ignoring the clarity that they should be presenting. So this is just a way to confuse the topic, but let's just see what else they say.
And in addition, the guideline development panel no longer recommends or endorses that a certain 25-hydroxyvitamin D defines vitamin D sufficiency.
I mean, that's just absurd. So now she's saying that the guidelines state that we just don't know. No level has any meaning. I mean, that's absurd. That's absurd. So, but that's how they confuse the topic. And that's the goal. That is their goal. Their goal is to confuse the topic so that doctors just ignore it.
Insufficiency, deficiency, this was different from their prior recommendations. And because of those challenges and the fact that vitamin D is inexpensive, taking vitamin D supplementation translates into about a cost of $10 to $50 per year. Contrast that with the cost then of having your vitamin D level measured. That is at least $25 to $100 per test, and that does not account for the other healthcare costs associated with having blood work done, nor challenges with some of the accuracy of measurement of vitamin D, nor the fact that there may not be access to vitamin D measurements. So all of that together led the panel with what I mentioned earlier, that vitamin D is typically safe to be consumed with few side effects for them to recommend against screening with 25-hydroxyvitamin D to determine who should be supplemented or not.
In thinking about vitamin D supplementation and the implementation of these guidelines, are there other things you would like our listeners to know or information that they could convey to their patients?
I think the main consideration that I would really stress, these guidelines, this update relates to patients who are healthy, and it does not apply to patients who have certain diseases that might impact their vitamin D metabolism, nor does it pertain to patients who have diseases that having vitamin D levels that are quote unquote normal, it would be important for them. So if your patient has advanced kidney disease, if they have malabsorption, if they are at risk for low vitamin D levels because of either their diet, being vegetarian, being lactose intolerant, being breastfed, or if they are on certain medications that might increase the metabolism of vitamin D, those are patients who you should screen with 25-hydroxyvitamin D. If your patient has hypocalcemia, low calcium levels, prior fragility fractures or osteoporosis, again, you should be screening them with vitamin D levels and ensuring that they are at least 20 nanograms per ml. And based on
20 nanograms per ml is complete deficiency. So that's an absurd baseline for her to reference.
Other clinical parameters, whether that patient has hyperparathyroidism, by way of example, you might desire a higher 25-hydroxyvitamin D level. But the key thing is that these recommendations are for patients who are healthy, and they are for the prevention of disease.
Well, thank you, Dr. Burnett Bowie, for joining us today to talk about vitamin D supplementation in healthy children and adults. I am Dr. David Simel. This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to this manuscript in the episode show notes. To follow.
So, obviously that's the end of the video, and it wasn't horrible, but it was certainly underpowered. And so, the typical busy family medicine doctor who may watch this video, what are they going to do with this data? Nothing. So they could have made stronger recommendations. They could have been more precise in their discussion of dosage per body weight. But this wasn't a horrible review, but it was still underpowered, and eventually this will do nothing. So they just used 18 minutes of time. They could have used that same time to discuss other clinical data that's much more potent. They could have talked more about dose-response relationships. For example, you may have noticed that they talked about a clinical trial series that involved 10 different studies. And what they did, look at the strategy that they used. They kind of pooled all that data together, and they said, well, on the average, we see this effect. Well, that's that's okay. But the other strategy that they could have used in addition to pooling the data is they could have looked at dose-response relationships. That would have been much more definitive. Instead of, if they take a bunch of studies and they pool the data indiscriminately, then it just kind of averages out, but we don't really get a lot of nuance. But what they could have also done is they could have looked at dose duration responses, and that would have been more definitive in terms of, oh, well, 600 units doesn't work, 3,000 units does work better, 4,000 units works even better than that. That would have been better. But overall, like I said, this wasn't completely offensive as I may have expected, but it also doesn't do anything. So, like, I just watched this in the same time that you did, and I don't get anything out of this. Like, what am I supposed to do? I'm supposed to not test. I mean, the take-home message that I get from this video is, well, don't test the general population. Test people who are at higher risk. But then what do I do? Am I treating them? Am I giving them 900 units, or am I giving them 3,500? If they're going to title this vitamin D guidelines, then make it a guideline that's actionable. I mean, this is just kind of a Melba toast conversation that doesn't move the needle one way or the other, but at least it wasn't horrible. Anyway, that's my quick review of this topic. Hope you're doing well. Take care. Bye.